we can start our webinar today on tech-based health and social responses to drugs problems. I'm particularly happy to give the floor to our new Chief Scientist, Thomas Clausen, for the opening remarks. And then after him, there will be the intervention of Ines Hasselberg, the chair for this today webinar. I close my camera, I remain in the backstage for help and have a wonderful webinar. Thank you, everyone. Thomas, the floor is yours.
Okay, thank you, Marika. And also on my behalf then, welcome everyone to this EUDA seminar on tech-based responses in the field of drug problems. So I am the new chief scientist at the EUDA. I've been here just short of a month now, and I'm happy then to have been given the opportunity to say some opening remarks on this webinar. Because I think the topic that has been put up for the webinar is very timely and relevant, and I look forward to this event together with all of you. I'm happy that so many have joined online. More probably will join as we go on. And I look forward to the sessions and discussions that will take place over the next 90 minutes or so. As many of you are aware of, this seminar has the structure of 3 planned presentations by experts from Scotland and Ireland, and it will be followed by a dialogue-based session with question and answers afterwards. We all live in a world with digital and technology around us everywhere. Many of us wear a smartwatch, we have a smartphone in our pocket maybe, and we spend many hours looking at it and working on it every day. So technology is integrated in our lives and in many of the services we use. Still within our sector, there seems to be a potential for more development to provide new and improved services and responses to those to more people, and namely those people who use drugs and are at risk because of that. So today we will hear from examples and experiences in how such technologies and interventions can make a difference in providing better health, even saving lives, and improve services for people who use drugs. Also, the examples will include how technology is important in improving training for staff in the services, again, to improve quality in the services. We know that there are gaps in our field between the service needs and the service provision in many locations. And for some of these gaps, I believe and think that new technology-driven interventions can make a difference and help narrow that gap in the future. I know that all the presenters are they have high in their minds the importance of the involvement of the service users in the development of such new technologies, and how to collaborate and involve and use the learned experiences when such new interventions and services are developed. So we'll also hear examples from that, how that is done, and I'm looking forward to that. Finally, we also know that in our field, it's a social gradient. Many people who use drugs, they do not have the same access to maybe digital technology and services as many others in populations. And we'll also hear examples how some of these projects have been able to provide new such devices or access to services to some of the service users. I think I'm not in a way the expert on this. We're going to spend the time listening to the experts and have the dialogue and discussion afterwards. So those were my introductory notes. I look forward to it. I know the experts are eager to start. And before I give the floor and word on to the chair, I'll just thank the organizers in-house and the experts that now are presenting to us soon. And with that, I'll pass on to the chair of the session, Ines Hasselberg. Thank you all.
Thank you so much, Thomas, and hello, everyone. It's great to see so many of you joining us today for this webinar. People who are leading some of the most interesting digital health initiatives in Europe. But before we get into the conversation, each of our guests, we have Alex Baldacchino, who is a clinical professor at the University of St. Andrews School of Medicine, specializing in psychiatry and addiction medicine. He holds key roles in several institutions, including the International Society of Addiction Medicine, the World Psychiatric Association of Addiction Faculty, the Scottish Government's Innovation Reducing Drug Deaths Consortium, and he has also been one of our very own scientific advisory members at the EUDA. We also have Catherine Kaminsky, who is a professor in healthcare modeling, global addiction, and transformation at Trinity College Dublin University in Ireland. She also holds key roles in a number of important institutions, including the Irish National Drugs Strategy Implementing Committee, and she's also an invited expert to the EONDC and has been part of the scientific committee also here at the EUDA. She has authored many scientific research papers and two very important books. One is Addiction Debates and also Addiction Research and Evaluation. We will post the links to her books in the chat so that you can look it up if you're interested. And finally, we have Maura McKenzie, who is a Deputy Chief Executive Director of Innovation at Scotland's Digital Health and Care Innovation. She's also the Principal Investigator for the Scottish Government's National Digital Lifelines programs. We'll hear more about that in a bit. And a co-investigator of the Summit program in partnership with Queen's University Belfast, Trinity College Dublin, and St. Andrews University. So you see, as Thomas says, and I mentioned as well, we have a very impressive lineup of speakers. Now, Alex, you've been recently set up with colleagues from the University of St. Andrews. You've set up an Innovation in Addiction Medicine Global Hub. Could you start us off by explaining what we mean when we talk about this, and also how these are shaping your current work? And just for everyone listening, again, the link to the hub and some of the links of the programs that we'll be mentioning will be posted in the chat so you can have a look later on. So Alex, I'll give you the word.
Thank you. Okay, thank you so much. Thank you, Ines, Thomas, and Marika for lovely introduction. And thank you for people who decided to register for this webinar. And I'm pretty sure you have very, very busy lives, but good afternoon or good morning to everyone. So my presentation, as Ines suggested, is about pieces of work that we've been doing at the University of St. Andrews for the last 10 years, but which culminates in some really interesting medtech products that I want to share with you. But before we start, I think it's important here that as the field is moving very, very fast in our own private lives, but also professional lives, it's always important to have some operational definitions based on the words that a lot of people use, and that includes technology and innovation. And you know, we all live in a world of technology, and some are new, some are not that new, but people who are above the age of 50, including myself, can remember things that were before the digital age. And as a result of that, you know, things that have moved on, you know, one obvious one is the internet. We're using the internet right now. But equally, we use the word innovation. Innovation is a process of having a vision, having an idea, having a very clear process around the need in order to find a new way of solving the problem, but also having that creativity, inspiration. But today, what we're going to talk about is those two together. And there are two terminologies that people tend to use: disruptive technology and innovative technology. Disruptive technology that disrupts the existing markets. And that's very much a business case type of way of thinking. Innovative technology perhaps is a more medical, clinical way of thinking about how to create and start, looking at prototyping and then going through the phases of creating either pharmacological product or otherwise. So, going back, we're talking of disruptive technology and innovative technology. And by the way, innovative and disruption does not necessarily mean a painful process. It could improve the quality of life of individuals. Now, this is not something new. WHO have recently, the last 4 years or so, have identified how important it is to look at innovative, disruptive, or innovative technology in order to improve the health of the world, health of nations, in order to drive health equity, accessibility, and positive health outcomes. And you can access these documents through the web. But what's important here, the message here, and this is the challenge, and even more in the field of addiction, in the field of comorbid mental health, substance misuse related issues, that we need to have health and social care related innovative ecosystem for the common good. And I think this is an important aspect, an important transition, that innovation does not necessarily mean is profit-based, but it should be value-based. And again, going back to this caring, compassionate type of disruptive innovation. Equally, the UN 2 vision towards 2030 is around using the current knowledge base, current technology, current opportunities to strengthen the expertise and the culture to build a UN system that can better support member states. And these two, WHO, United Nations, are fundamental to the issues that we're going to discuss. I put this here, as a reminder. We talk about drug use, but it's a population that's highly stigmatized, stereotyped, and there's a high level of morbidity and mortality. And this is from the recent European Drug Report 2025. What is interesting is that the novel technologies are realizing that perhaps even the data that we produce, the data that we assimilate and try to link into meaningful, important predictions of the future, are partly flawed, either through underreporting or through the fact that the definitions and the way we identify cases are underrepresented. So even though here we talk about an increasing in drug-induced deaths, it is important to look at this as an example of how disruptive and innovative technology can make this reporting even more accurate, but most important, even more intelligent, in order to be able to understand the populations, understand the vulnerability and the resilience of these populations. And I put here addiction medicine. I meant, addiction here in totality, addiction care is uniquely challenging. We talk about complexity, we talk about stigma, fragmented care system, and in some cases, reimbursement complexity. We talk about the totality of a biopsychosocial perspective, which makes it even more complex. And also the asymmetrical innovation. As a psychiatrist, and working in the field of addiction, I'm so much aware that a lot of the innovation is around pharma, is around creating either new delivery of new packaging of the same pharma, or going through clinical trials to identify what could be the best pharmaceutical product that could help people with substance use related issues. So this is a visual representation, a systems map around what we're actually talking about here. And I purposely didn't put it on high resolution so that you won't be able to see it. But I think the message here is for you to understand that we're dealing in issues, complex issues. So as a result, if we are able to utilize the new novel technologies in order to help us in understanding clusters, in understanding prediction, understanding prognosis, and also preventing further harm, I think we should welcome that. But it's not easy, it's not impossible. Which leads me to this notion, going back to very, very simplistic terms. We talk about mortality and how in the last 20, 30 years, we've been siloed in our way of thinking. We do not get out of our comfort zones. We talk about drug deaths, EUDA is about drugs. What about the alcohol? What about the mental health? It's someone else's problem. But when we talk of the same population, we realize that, for example, in Scotland, I compared the Scottish here with the European and the US, we have on average around 3,000 individuals who are of the same community who die either of a drug death, either of suicide and alcohol use disorders every year. And when you look at that and you're able to perhaps, revisit how we are able to understand and use technology, I think that's quite a helpful and refreshing way of perhaps in due time able to save those lives, which are mostly preventable. Now, I've put here this article, which was given by my esteemed colleague from the business school and published in Discover Health Systems. And it is about the role and impact of new technologies on healthcare systems. Again, I'm not expecting you to read on this, but it's quite enlightening how much we have advanced in this field. And I remember in 2015 presenting this type of resume around what type of technology 10 years ago. And I remember half of those that have been mentioned in this article, I've put in as a section Star Trek vision. Hey, in 10 years' time, we're talking of realities that are either in experimental or are already applied. But, let's go back to us, ChatGPT is with us. There are other products, version 5. We utilize it every day without either knowing or purposely. So let's not be afraid of this technology. So potential fields of innovation in the field of substance misuse include the use of digital health telemedicine, pharmacological, pharmaceutical, biotechnology and neuroscience like neurostimulation, behavioral, psychosocial, virtual reality or augmented reality using blockchain for patient data, behavioral economics and cryptocurrency-based rewards, digitalized integrated care models, delivery systems. The reason why I'm not going to explain, every single item of this, because we don't have time, but more than happy to talk about, with individuals who are interested in these particular elements. But this is where currently technology, disruptive technology or innovative technology is being used in the field of substance misuse. And this is another article perhaps worth considering. We looked at, are we ready for big data analytics and artificial intelligence? And where we explain how we are already using AI or machine learning and data science and implementation science in the field, and how we can improve improve resource, improve staff being trained in these fields. So vital parameters is important when we talk about disruptive technology, is that it's inclusive. It helps in the transitions through care, embracing the complexity of care, which would increase service resilience, important and relevant information and intelligent data, definitely multi-agency, and as I mentioned earlier, digitally enabled workforce. with stigma reduction. Just to give you an example, these are technological products that have been in the market for quite some time. I mean, for the last 7-8 years. And we wanted to understand 4 years ago if some of these are actually still being used or are in the process of being used in the field of substance misuse. And as a result of that, we've set up through the Chief Science Office and subsequently with the Office of Life Science UK government, an innovative priority, a challenge call to look at the digital technological and therapeutic solutions that are intuitive, user-focused designs with the requirement that all these new technologies would have a co-design and a co-production process with service users. And the call was around what type of technology is there in order to support in a timely and effective manner people who are overdosing and potentially dying as a result of a drug overdose. And I'm glad to say 3 years from obtaining money from the Office of Life Science and Chief Scientists, we have 7 products, which are right now going through the stage of going into the market. And these include like the assessors, which is a soft skin interface sensor for overdose detection, which can be built into your garments, tops, socks, t-shirts. Then we have EUDA, low-cost AI-enabled drug overdose monitoring system, which is an alert system that is connected with the community, either via satellite, but not just with ambulances, but peers and other communities who are aware of one person's use of substances. Then another wearable device of multimodal monitoring of oxygen saturation, heart rate, and respiratory rate for opioid detection. PneumoWave, which is again a remote monitoring platform. And then we have a low-cost alert and responding pathway. And going into the actual overdose interventions, very soon you'll be seeing in the market an ultra-portable fast dispersal, buccal naloxone. As you know, right now we do nasal spray and injections, intramuscular injection. In this case, it was a buccal spray. And the rescue patch, which not only includes naloxone, but also the benzodiazepam antidote flumazenil. Now, last but not least, what was the lesson learned of these last 3 years is, number one, constantly acknowledging the digital divide. We need to reach out in different settings. We needed to combine with face-to-face intervention. So this is not an alternative to current services, but an add-on. It needs to be flexible, continuous, data security, privacy, of course, sustainability, and need to strengthen evaluation to be safe and effective. Lesson number 2 is we need to engage stakeholders early, and that includes patients with lived experience, but also other stakeholders who are part of the ecosystem. We need to ask the question of who, why, and how. So these are important components that, as we went through these projects, we are constantly asking if there's, not only as a part of an iterative process, but also asking ourselves, are we missing anything here that would improve the solution, because we're understanding better the need for that particular product. Common pitfall here, designing in a silo, then discovering too late that doesn't fit into the workflows. Problems with clinical trials. Last but not least, we realize that it's still in its infancy. When it comes to outcome measures, we talk about evaluation, but actually in this day and age, I think we need to go beyond health and social care outcomes and look at the technology itself. This is, as far as I'm aware, the one and only paper that through a Delphi project looked at what actual terminology is being used and what outcome measures should be used when evaluating overdose response technology. So last but not least, we're as part of the International Society of Addiction Medicine every year. We have an Innovation Day pre-Congress. This in 2026, it will be in Rotterdam on September 30th, but going back home to St. Andrews, please look at the Digital St. Andrews website, which I told you has been doing all sorts of different types of work around in the field of overdose prevention, data science and implementation science, but also watch the space around an exciting collaboration that we have with the business school at St. Andrews, together with 7 other schools, including physics, mathematics, computer science, anthropology, and others, of a St. Andrews Ideas Lab, within which we will be able to look at how we can provide compassionate, caring innovation and working with different stakeholders, including individuals with substance misuse and lived experience, but also with entrepreneurs and philanthropists who want to invest in this field. So with that, thank you for our investors and sponsors, and thank you very much.
Thank you, Alex. That was a very engaging and impressive presentation. Your systems maps is already generating some interest in the chat. I'm sure other people will have more questions and comments for you, but we'll save that for the very end. And so now we'll move on to Catherine. And Catherine, of course, an important issue, picking up also on the lessons learned that Alex has just talked about, is about understanding needs and developing evidence and figuring out how to put that evidence into practice. And all of these are things that you've worked quite extensively on and are now applying that experience to digital innovations in this field. Could you tell us a little bit more about that and about the Summit project that you've been developing?
Lovely. Look forward to that. Thank you very much, Inez. And thank you, everybody, for attending. Just wonderful there at the beginning, looking at everybody coming into the room. Thank you so much for your time. I see we have people from Tunisia. We have from Lisbon to Limerick. So welcome, Limerick. We have the Northern Europe as well. I see we had Sweden. We have Romania. So thank you all for attending. So a little bit different to Alex. I'm working with Alex on another project, as you'll see presently. I'm going to talk just about very practical, because that's what I do. I do the research, but also I'm very practical and like to answer sort of practical questions. And I'm going to give you 2 examples of some work we've done here with my team. One is a smaller sort of project, and then moving into a larger project. Because I am conscious that we come from different resource settings, we've got different systems, and we have different challenges. So the past example is going to be looking at bridging a nursing capacity gap. Now, I'll be speaking about nursing, but it could just as well be about outreach workers. And I know I have Tony Duffin I saw he joined us there in the group as well, who's worked for years in wonderful outreach services. It could be outreach, it could be community services, it could be a needle exchange bus. This particular application is with nursing, but again, our approach, I think, is applicable wider. I'm going to talk about that past example on how we used innovation. And I'm also going to tell you, we didn't know we were going to use innovation. We just knew there was a problem that needed to be solved. And how did we go about solving it? That's the past example I'm going to speak about. And then the current example, the special EU programme body, the PEACEPLUS funding, and the Summit project, and I'm going to talk a little bit about that. And that's the project that I'm currently doing with Alex and with Moira, who are speaking here today. And then I'll give you some concluding thoughts. I just share this little slide with you. I love this slide because it's like a miracle occurs. I originally studied mathematics in my degree, and I often sat at the back of the class thinking, oh my God, how are we going to solve this problem? And, you know, the professor would be at the board, and I think, how did they do that? Or it's usually he, how did he do that? And I've realized, I suppose, with my own research, is that you don't necessarily know all the steps, but you figure them out as you go along. And it's only really looking back, you think, gosh, a miracle occurred there, because you don't necessarily know the answer when you're starting off, but don't let that stop you from starting. Okay, it's step by step. So the first project was a real example of that. This is where we developed and implemented an evidence-informed, what we called a massive open online course. So I'll explain a bit more about that in a moment. For this recovery, this addiction treatment model, a way of working, a nursing model. So I'm going to walk you through the steps that we arose. I work in a school of nursing and midwifery. I have been the head of the School of Nursing and Midwifery, and we have like about 150 staff, but I am not a nurse. So I knew very little about nursing models when I was asked to take on this project. So again, a bit like that, a miracle had to occur. But you don't do this work on your own. As you can see here, this project was involved with quite a number of people. And when we went to do the massive open online course, we even involved even more people. I've deliberately left the European Monitoring Centre for Drugs and Drugs Addiction name there, because that's what they were when they were working on this project with us. The Anna Liffey Drug Project, former CEO Tony Duffin and now Dawn Russell worked on this, on the MOOC with us. We had a maternity hospital, a midwife. We had a gentleman who drove an ambulance from in Kenya that I had been in correspondence with. We had a fabulous lady, Julie MacDonald, who works for TB and HIV care in Cape Town. She also was involved in this, and she works out in rural South Africa, that we met at a conference and just chatted. And Malukan Basa, now Dr. Malukan Basa, who was actually from Ethiopia, and again, very rural services. And then colleagues here in Ireland worked on this project with me as well, and their names are there. So you don't know who you're going to be ending up working with, but you meet people along the way that you can learn from and that you can bring into your work. And that in itself is an innovation. When you bring in other thinkers and challenge you to think about your solutions or your problems and how to go about solving them. So what was the background? The nurses had a problem. All right. So leadership within the nursing realized, look, we need to really look at our model of practice. So this was in North Dublin. There was a very small team of nurses. Oh, brilliant, brilliant, absolutely excellent, providing fabulous service. But they had a review of their services and they said, you know, your practice is reactive. You're not planning, you're reacting to everything that's coming in the door, as we so often do. You're just dealing on a day-to-day, what's coming in the door, how am I going to get through this, instead of sitting back and trying to have a more proactive service. They had over 2,000 clients on their treatment list, and they just felt we're being very reactive. So they said to me, Catherine, will you help us develop a more effective nursing model? And I said, I can only do that if we look at client need and look at the literature. And this is an example of client need. If you think, this was a young man that I actually interviewed for this project. He was now going to be a father himself. But this was the life that this young man had grown up with. And you can see the amount of trauma. And I use this example in some of my classes. This young man, when I was interviewing him, rolled up his trouser legs to show me his bullet wound where he had been shot when he was 17. And it was that event that his older brother actually got him out of the environment and moved him to a more rural area in Ireland. But this is the sort of challenges perhaps that you might be facing in your practice, whether it's a nursing practice, whether it's a needle exchange practice, whether it's an outreach practice, whether it's a homeless service or so forth. Very, very traumatic backgrounds. I just move these slides on. So we said, okay, we need to look at the needs. And we went out and we spoke to about 130 people in the area who were using the services. And we not only measured quantitatively their needs, but we also spoke to them and we interviewed them. We have hours of interview tapes because as we were measuring physical and mental health and psychological needs, conversations happened. And we discovered a lot more needs as well, you know, as people spoke to us about their needs. So that was the first thing. We said, let's look at the client needs. Then we said, well, let's look at what the nursing needs are and what are the needs of a model, a nursing model. So we also did the background literature review. And we looked at, said, well, what does the client tell us and what does the literature tell us about a model? And in terms of a nursing model, the client need is the most important thing. And then a model has to be adaptable. In this case, it had to be nurse-led. How do you know if it's working? It has to be measurable. It has to be implementable. It has to be cognizant of the person and their environment. And in this case, you know, with nursing, it's more holistic. We must have a biopsychosocial support approach. And finally, we said we need to use a brief intervention because the nurses I was working with were general nurses. They were not mental health nurses, but yet clients were coming in with many and varied needs. So I developed a nursing model to address these and the client needs. And we called it the Healthy Addiction Treatment Model. And you can read about the details of that. And then we said, well, does this model actually work? And we did what we called phase 3 at that stage to see, did the model work? And could the nurses work with that model? And the model focused on what is the greatest need of our clients. And in this case, it was the psychosocial supports. Now, the nurses are not mental health nurses, and they're not psychologists, and they're not counsellors, but they still provide a brief intervention. If somebody is in with a wound dressing and talking about, I have a court appearance next week, I'm very anxious about that, conversations happen. Can the nurse provide a brief intervention during that general nursing interaction? So we said, right, we need training. And then we said, how do we train all these nurses and all these clients and staff? So we discovered, again, we didn't know this was the solution when we started off, that there was what we called a massive open online course. So we applied for some small funding. I think it was about 25,000 euro from the nursing board, the National Nursing Board, to develop this nursing model and a massive open online course, this course. So it was to provide training for the nurses and the allied health professionals on this MOOC. It'd be a free course, so people did not have to pay for it. It had to be accessible to large numbers of people. It had to be at a certain level so that people who didn't have a third level education could access the material and be accessible, open to the general public as well. But it was informed by all of the learning that the academics, the nurses and the clients had brought to the model. So it's a massive open online course. Just moving the slides on. What's in a MOOC, a massive open online course? There's short videos, there's audio pieces, there's small written pieces, there's maybe reflection pieces, there's a forum for discussion with other people around the world about how they're progressing on this course. It is only 6 hours long, it's over 3 weeks, and it's 2 hours a week. So then we had to go, and with the nurses and the clients, we had to actually develop videos, we had to write short articles, we had to design assessments to get people to think about what they were learning, and then we had to look at implementing it. And here is the end product. So anybody attending this webinar today, you can go online and you can undertake this free training. It is training in this healthy addiction treatment model, but it's also training in leadership and some training in brief intervention. It's 6 hours over three weeks, 2 hours a week. And you can see here, it is started off for nurses and midwives, but at this stage we've had over almost 3,500 people actually globally do this course. Now, when this massive open online course, as I say, when we started, we did not know this was going to be the answer, that this innovation, if you like, was going to be the answer. So please don't be put off. All right. Address the challenge, look at your client need and say, what can I do next? What's the next step? What's the next step? And just go one step at a time and bring all that learning with you, and the learning from the client, the learning from other services and so forth with you to arrive at your solution. Which brings me to my next project, which is quite a different project. But before we started this project, before we actually got the funding to do this project, there was over 2 years of learning that brought us to this. So this is the Summit project that I'm doing with Alexander and with Moira. It's substance use and mental health interventions using digital technology. None of us know how this project is going to work out. We don't know the answers yet. We've just been given money to find the answers, but we don't actually know the answers. This is the project that we're doing with Northern Ireland. Northern Ireland, as you know, is part of Great Britain. The United Kingdom of Great Britain and Northern Ireland is part of the United Kingdom. And then the Republic of Ireland is a separate, legal and republic to the UK. But across the border, there are common challenges, both north and south of the border. We're actually a very, very small area, but we have common challenges, but we have 2 different systems. But people who use substances, drugs and alcohol, they have common challenges, whether it's rural, whether it's coming out of prison, whether it's mothers in addiction treatment, there are common challenges. So we want to share the challenges and the solutions and the technology across the border. And we decided to apply for this, what's called the PEACEPLUS program. And this is with Queen's University, St. Andrews and DHI with Moira. So it was very important we had an integrated approach, that we were looking at new technologies to tackle health inequalities. It was to look at cross-border and specifically mental health. Now, we didn't just go out and decide we're going to do this. This is mental health. We actually, in part of our preparations and our learning, again, we didn't know that that was the answer. In our sort of 2 years preparation, we did, as part of the research aspect, we did actually what we call an evidence and gap map. And we looked at all the different sort of data sources, spoke to people, there was preliminary work done, and we said, what is the evidence and what are the gaps? And we looked to see, how do we fill those gaps? And that is what we came up with. So we came up with common challenges, sort of the lack of integrated treatment services for substance use. Like that gentleman, John, at the beginning there, you have to tell your story, maybe in the mental health service, in the addiction services, the children's services, maybe at your school, the principal of the local school, because that's where your child is. I'm sorry, this is why my child is late. This is why she doesn't have a clean uniform. This is why there isn't a new uniform. This is why we haven't got the books. I mean, there's just so much going on in people's lives that are challenges. And this project hopefully is going to help solve some of those key challenges. There are barriers. So what was the summit aim? It is substance use and mental health interventions. And we're going to look over a 4-year period. We're going to work with about 1,500 people in these border areas, and working with Scotland, who have done similar programs, as you've heard there from Alexander, learn from their experiences, learn from the needs of the people in our regions and the services in our region, and we're going to be implementing technological solutions. We don't know the answers, We just know the challenges, but they're evidence-based challenges. We didn't just pick them out of the air. Sorry, just wait for this. These are the sort of work packages that we have. We have 4, and Trinity, that's my team here. Karen Galligan, Dr. Karen Galligan is online here. She is project managing this for me. We are going to be doing the research and evaluation aspect of this work. Moira and Alexandra and Professor Catherine Higgins, who, this is one of her slides, she is going to be the overall PI. So here are some of our objectives. Collaborate with 4 local areas. We're doing cross-border. We're going to look at good practice, address inequalities, and deliver training programs and enhance social. We hope, that's part of me, I'll be measuring this. Are we actually working? Are we staying on track? And we're hoping to enhance care and to also enhance training. These are the different locations. I'm conscious of the time, so I will keep going. We have our 4 locations. And I suppose, moving on to the final slide, thank you. One challenge, and here are some future readings, these are some background readings, but Alexandra did speak about future challenges. And one, I've just finished a course myself, because I'm always learning, on generative AI, because like that, I don't know enough about it. But this is going to be a challenge, ensuring that ethically, that all of the people in our cross-border regions have access to quality services, have access to those innovations, have equity access to artificial intelligence or other types of services. And this is something, I mean, artificial intelligence and generative, that's that which, you know, learns from the past inputs. This is going to be a future challenge to ensure that we remain ethical in our practice, that we remain ethical and whether we have equity across our services. But as I say, I'm always learning. We don't always know the answers. We learn as we go along. And I hope that these 2 examples are one of where we have learned, and the Summit project is where we still don't know the answers, but we're looking forward to learning. Thank you. Happy to take any questions. Thank you.
Thank you, Catherine. What an inspiration. Amazing. And again, already generating so much interest in the chat. For everyone out there, stay tuned. All the related links are or will be shared in the chat. And you will also have the opportunity to ask questions to Catherine and to the other speakers at the very end of the conversation. But for now, we look forward to hear from Moira. Now, Moira, you've been working to make sure that digital tools really reach people and make a difference. And you have a leading role at the Digital Health and Care Innovation Centre in Scotland. This centre being the home for the Digital Lifelines project, if I'm correct. Can you please tell us more about it and your work in this field?
Hi, Anish. Thank you very much for that introduction. I'm just waiting on the screen sharing coming over, and then I'll start. So my presentation today is going to focus on the experiences from a practical implementation of a programme in Scotland called Digital Lifelines. But before I do that, I'll just say a small amount round about who I am and the organisation that I'm working for. So, Anna, I can change the slides, that's good. Okay, so I work for Scotland's National Innovation Centre for Digital Health and Care. So we are a public funded organisation that looks to see how we can identify, design and develop digital solutions that support the transformation of health and care. In doing that, we also support programmes round about skills development and also economic development. So looking to see how businesses as a partner in some of these initiatives can actually help us drive forward. So very much that triple helix idea that many countries have already. So we've got 2 locations, 2 physical locations in Scotland. One is deliberately in an urban space, a high density of population space in Glasgow. digital. The other one is rural in nature, again, recognising the benefits of utilising digital within different environments so that we're able to test them out and see if they can benefit our wider populations. We are hosted by the University of Strathclyde, but we're also in an interesting collaboration with the University of Glasgow through the Glasgow School of Art. And the Glasgow School of Art are bringing a co-design mechanism to the programme that very much looks at how we support person-centred digitally enabled services. So very much coming at it from the perspective of the person, and then looking to see how we embed those within the health and care system, so that they can be adopted and scaled. And because there's quite a lot of activity going on within the treatment space, our interest is more predominantly on the very early intervention, early detection, how we support people within independent living and within our communities as well. So progressing that forward. In terms of our methodologies, what we do is not just take a piece of technology and somehow try and land it within a service model, because time has proven that that's not a particularly successful approach. So we progress it on 3 broad areas of methods, and we intertwine these. So very much looking at what the current service models are, where there are opportunities for digital interventions to take place and what those might actually deliver. Where are the technologies at in terms of their development, and also, frankly, businesses need to make money from selling some of these devices and initiatives, and what is the commercial model that would be most sustainable for them to be able to support the economic development element that I touched on earlier. DHI published its 10-year strategy last August, and what we did when we were looking at that was what is going on internationally. So globally, what are the digital trends that are out there? What's the key priority areas that we should be focusing on to move things forward? And this very much underpins the programme that I'm going to tell you about today. So again, we try and not look myopically at a particular issue. We try and look at it across the very complex environments that we all work in to make sure it's as sustainable and adoptable as it possibly can be. So the project that I'm talking about is Digital Lifelines Scotland. It is a project that has been provided and delivered in partnership with third sector organisations in Scotland. So working with delivery partners from the Scottish Centre, Scottish Council for Voluntary Organisations and Simon Community Scotland. So 3 very valuable frontline delivery service partners that are able to help us embed these developments as we progress. And again, that's been an important learning point for us all in Scotland. The programme has been running for 5 years now. We've got a kind of penciled in 2-year extension beyond the 5 years. And to date, we have committed 4 million funding to this. I appreciate that that may be very different from other environments globally and internationally. So again, just to share where we've got to with some of that. But the lessons that we've learnt are obviously transferable across boundaries. So it's a programme that has been public sector funded by Scottish Government, particularly their Digital Health and Care division initially. So they were looking to see how digital could support a range of health and care issues. And they saw during COVID the issues that were around for people who were living with addictions, and how within that COVID environment support could be delivered to them more safely. So we are now increasingly working with the Drugs Policy Division in Scottish Government, and our previous Drugs Deaths Task Force were a driving force sitting behind the programme as well. But you can see there are a range of different partners with different interests that have been involved in the programme from the beginning. The overall aim is kind of a tripartite aim, so really looking very much at what are we doing in the programme for people themselves? So how, through the use of digital, are we able to keep them connected to services that keep them safe, and how we keep them connected to their family, friends, and other support mechanisms that they might have. And we are also trying to connect the services up. So very much we talk about the lack of joined up care in many service provision areas, and the ability to share information. So how do we support through digital the ways that we can support those services to join up more effectively to deliver the care that they need to the people that require it? And very much looking at, as I say, the sector as a whole, so individual services and how we upskill those, but the sector itself starting to develop much more integrated approaches and joined up solutions as we go forward. And the programme has taken kind of probably two broad areas. So I'll kind of simplify it because there are a number of activities that we're progressing. But the two main areas that we looked at were digital inclusion. So recognising that many people living with addictions were perhaps already excluded from digital, and much of that is around about the cost of connectivity, so the cost of data and how they manage to sustain that. But there's also other factors in digital inclusion that the Scottish Council for Voluntary Organisations has researched and detailed on the left-hand side of the slide. So to bring people into the digital world, there's got to be a range of supports that are provided. So what's the motivation for them to go digital in the first place? Why would they do that? What's the right device for them? And where they might be round about perhaps literacy levels, or if there's an interest in trying to engage within the education system again, you would need different types of devices for that. Building up skills and confidence in the use of digital. Again, there are concerns round about security, how might people access their devices, also privacy concerns as well. How do we work with people to provide them the assurance and the skills around about that area, and very much designing the whole approach for inclusion. So how does it connect to health and care services, and what does that feel like? And we've touched on affordability and connectivity already. The other wing of the programme has been looking at what types of digital products are out there and what types of services. And Alex touched earlier on some work that St Andrews and the University of Stirling had undertaken about 7 years ago, looking at what the products and the services were on the market at that time. And the findings were that there were products and services, but many of them were very immature. They were at very early development stages. They were perhaps sitting within the university landscape and hadn't been fully tested or exposed into either a living lab environment or indeed out there at scale. So we were looking at, what types of services did we need within the programme, and could we develop insights to develop those as we progressed. And I thought I would share quite early on what the deliverables were, kind of 3 years into the programme. So for April 25, having started back in March 2021, we were looking at, as Catherine was touching on earlier, we did not know whether this was going to work or not. We didn't know the answer. We didn't know how to navigate it, but we knew we had a problem that we needed to come up with a solution for. So what you see in front of you here are a number of outputs, and very much a methodology which is predicated on learning by doing. So by putting that whole approach to digital inclusion out there, looking at 3 digital products and services, we have connected already with over 5,500 people who were at risk of harm through their use of drugs. And we have helped upskill over 500 staff and volunteers working in digital services. So you'll see some of the other statistics there, but pushing out a number of devices, pushing out that connectivity, working with people at the front line around about how we build up those skills and confidence, and then starting to introduce them into digital products and services. So we've touched on that one already. You can see again these are trying to tap into why people would want to go digital and what their particular area of interest was. So people themselves don't necessarily think front and foremost in their minds, I'm trying to manage an addiction issue. They've got a range of other issues that they're trying to manage in their lives, be that access to housing, debt advice that they're looking for. How might digital actually help with some of those before they start to look at specific products that might support them in terms of managing their addictions? And many people have lost connections to their family, their friends, and again, really keen to build up those connections again has been part of the motivation for them engaging in the programme. So some of the products that we looked at 3 main products. One of them was based on an application, the Brave app, that was developing in Canada. And what we were looking at was how transferable was that product to a different environment in Scotland and a different culture. So basically it was a smartphone app, you downloaded it onto your phone. When you were about to take drugs, you connected to a volunteer or a friend who was able to be monitoring you remotely. And then obviously they linked in with you if you did not get back in touch within a kind of predetermined period of time. The finding from that one was, that was a kind of 8 months project. It was a pretty short timeline, just by the way that we had to get through information governance, other practical issues that we had to navigate before the tool could even be introduced in the first place. But working with Alcohol and Drugs Action in Aberdeen, there were 19 service users introduced into the project over that period of time, and there were 74 calls logged over that period as well, which was actually really good at that period. And the kind of findings from that were very much there was lots of potential. I mean, it basically operated as a virtual consumption room. There was a lot of interest in it, a lot of enthusiasm for it, but key findings that were coming out were there needed to be ongoing funding beyond a project timeline. There needed to be dedicated staff attached to it. And most importantly, it had to be available 24 hours, 24/7. So 24 hours a day, 7 days a week. And that wasn't possible with the restricted funding that we had available for this mini project at that moment in time. But lots of learning coming around how people engaged with it and where they felt its benefits were. The second one was developed by the University of St Andrews, so Alex and his team, looking at a video consulting platform that we already had in Scotland that was used by the NHS and increasingly social care and third sector services. So how did we have to review that technology, which was in fairly broad use in Scotland, for supporting people living with drug issues and other addictions? So that was very much a kind of academic engagement piece, but speaking to users of services, speaking to staff operating in those services to say, how might we adjust this and would you find it of benefit in terms of supporting addiction management? So again, lots of learning coming out of that, that again, we're looking to build on as we progress. And the third product service that we developed, building on work that Simon Community Scotland and their partners had previously developed, was looking at a navigation app. So again, smartphone based, how did people living with addictions find services that were in their areas that were going to be of use to them? What kind of information could we deliver through the app that would make, say, injecting practices much safer? And increasingly, we're looking at alerts and how we can localize some of those alert methodologies, so that again people knew what was circulating in their area at any given moment in time and take appropriate action to that. So that one is actually going from strength to strength now. We developed a minimum viable product and we are now looking to see how we expand it further, build in extra functionality and get it adopted within wider areas in Scotland. So that was our kind of first 3 years of the programme. We're now looking at what the forward plan is for this next period. And it was very similar going forward. So again, the experience that we've had to date is giving us the confidence that even although the context in which we're working is continually changing, as it will be for yourselves, you know, the statistics are shifting. We are now looking at a cost of living crisis as opposed to the pandemic. Other very interesting changes going on in our context, as well as elections and the huge financial constraints that are going on within our public sector services at the moment. Again, different in different contexts. So these are all things that are changing the way that we want to move forward. So again, we've got digital inclusion as a fundamental element of it. We need to get devices and connectivity out there to people where they are at in their local communities, and we need to engage with the staff and the services to build up their skills, their confidence, their motivation around about using those devices. So we're looking at, our targets are very much about a minimum of an additional 1,500 people being supported in this way, and we have specifically identified 2 localities in Scotland, so one in East Ayrshire, one in Angus, so again east of Scotland and kind of further north, where we're looking at, if you're doing this in a much more focused place-based approach, are you able to build in those joined up services, that sectoral change that we see as really crucial moving forward. So very much working with the range of organisations who are on the ground, working with people and engaging as part of that co-design process with the groups of people themselves. So we have identified transition points are really our points of issue in Scotland. So focusing on people who are homeless, people who are being released from prison, and people living very much in deprived communities or managing other issues in their lives, such as mental health challenges. These are the people that, frankly, for us, are falling between the cracks a fair bit, and that we need to be reaching out to try and support their healthy outcomes. And our digital services side of it, we've got a number of opportunities in this space, and part of the dilemma for us is choosing which ones we want to progress within tight timelines and that won't cost huge amounts of money in terms of development. So we have already agreed that we're going to progress the navigation app that I talked about earlier on, and build more information and localise that much more as we're going forward, so that again, when we're talking to the East Ayrshires and the Anguses, it makes sense for the people living in their communities, and it's not some vague general information that doesn't really resonate to them, or they don't get linked into the services that are working in their area. So again, working with a database resource that pulls localized information through into the app and really makes that of value to the individuals living in those areas as we progress. We've got these other opportunities, which I won't go into a massive amount of detail on, but again, looking at how we build on the work that St Andrews has been doing to look at that, potentially the video consulting platform, and now from the insights that we've gathered through the research and the evaluation, can we make sufficient changes? Can we target that to the people who would most benefit from it, and also manage the risks around about patient safety if you were trying to support people who've got perhaps a more chaotic drug use pattern than which would present its own issues. So yes, lots of opportunities in there, but yes, it's kind of stepping forward sensitively. And the kind of second last slide for me is communication and engagement and learning, and all of this is crucial. So how do we share the learnings that we have been building up over the last period of time? How do we look at the programme connections that we might progress with others as well, either locally in Scotland or with colleagues in Ireland that Catherine's already touched on? We have got a community of learning already up and running, and we have an annual conference event that again are open to others should they wish to join, to learn from those practical experiences as they are emerging. And we've got research partnerships in there as well that, you know, new opportunities will be coming along all the time. How do we find out about them? How do we work with others in the research and the research landscape to build on the programme and increase international engagement? So I know we want an opportunity for questions and answers, so I will end there. QR code there if you want to scan it in terms of accessing the Digital Lifelines Scotland website, where there's lots of background information on evaluations that we've carried out, other day-to-day interesting stuff that people can learn from as well. And again, it is a learning programme, so delighted to hear what other people are doing, if there's things that we could be joining up with or learning from each other. Thank you.
Thank you, Maura. Again, another we have a very engaging audience here today, and that you will get some comments like you were asking, and there'll be great discussion. And for us, I think it's great to see that this webinar is actually providing also an outlet for these discussions, and how your three presentations just are mixed and flowing from one another. So Alex, Catherine, Maura, thank you so much for sharing your thoughts and your experience. It's provided us with really great insights, a lot of food for thought. And again, thank you to all of those listening. I find we have really engaging audience. We're going to open the floor to questions for the audience. Before, I'd just like to ask the three guests if there's anything they would like to add or comment to what has already been said. Also, Thomas, feel free to say something if you will. And
maybe
Alex,
we move to the
please.
questions. Sorry, I don't want to interrupt. We have 15 minutes to conclude, so probably we give space to the questions, and then we ask the conclusion remarks. So the first one is always difficult. There are many. We need to pick some of them. The first one is about how motivated are drug users to actually use those tech tools. As a stigmatized group of people, the design of those tools need to be taken into account as not to make them feel like they're being, for example, further treated like criminals. I think Moira provided already an answer, but maybe she wants to start speaking on this. Thank you.
Thanks, Marika. Yeah, so co-design is a fundamental part of the approach that we're taking, both to Digital Lifelines and to the Summit programme that Catherine touched on as well. So that means involving people. We've got the challenges around about ethics approval and the time that all takes. However, it's fundamental to the work that we're doing that we have to engage with people, and that it has to be something that's important to them. So part of the experience that we've had through Digital Lifelines is finding out what it is that the individual wants to do with the digital technologies, and then using that as the focus for any upskilling or work that we would need to do with them. So the example that I often give is a gentleman, and on our website there's case studies of individuals and what they've got from the programme. So I talk about a man who wanted access to his daughter. He'd lost access, managed to get access to his daughter again at the weekends. And he first went online because he wanted access to the digital channel so that his daughter had something to watch when she came to stay. So once he did that, he was then introduced into that wider world, saw the benefits of connecting up with other services, etc. And that really got him on his journey. So you need to find the hook that they're interested in as an individual that's going to add value to their lives. It's not something you can force on people. And the types of devices can change, but they can be very much predicated on what they're interested in that time. So that gentleman wanted a small tablet device because you needed to watch video on it. Others may just want a 2G phone because they don't want a smartphone. It's too confusing for them. They've never used it before. So trying to match the device and the connectivity to the person is what we need to do to fundamentally get that take up.
Thank you. Catherine and Alex, would you like to add
Well, I
something?
would just add that it also takes time, and that's something that I've learned as well, particularly from Moira and her team, is you don't jump in with the solution. You let the answer will emerge through that engagement. And also I've done evaluations of co-design and looking at the principles of co-design, the power dynamics, making sure that voices can be heard and that there's an opportunity for all voices to be heard. So it's not just doing co-design, it's doing it right as well and being aware of some of those principles as well and giving it time. That's really, really important. Thank you.
I think very, very quickly is doing it and sustaining it, and co-design. Fundamental. I mean, there are some other questions there around the fact that it is not about the digital, it's not about the products, it's not about the innovative technology, it's about the people. So if you start understanding the people, and I mean here, we seriously have a problem with stereotyping and how important, and still we do not know what are the major communities there that need digital design. We assume that everyone needs digital design. We don't know. Sometimes perhaps, providing digital design can make the situation worse. So it's a continuous process of understanding the users and the community. Thank you.
Thank you. I think this also answer other questions. And there is a comment and a question by Sida Kiak. She finds very positive the training availability, but she's touching upon a point that is particularly important also for our agency, that is availability on different languages. Have you thought of potential solutions for that?
I saw that comment actually, and I thought, very good comment. But I mean, as I'm learning more about AI technology, I'm aware that I don't need to know all the languages. The MOOC that we developed is in English, but with AI technologies now, that could very easily be translated into other languages at very, very little cost. So I think these are examples of where you may have done something in the past, but actually we can do better in the future again by what is available now, because that level of AI wasn't available when we designed the MOOC, but it is now. We're designing a new MOOC at the moment on neurodiversity and people who use substances. And actually that comment from that participant, and thank you for that, has actually challenged me to think about it. Well, actually, maybe I do need to be more aware of this and use, because I know at the EUDA that you have that challenge as well. So thank you to the person for that comment. And I will be taking that comment forward for my next MOOC, which we're doing at the moment.
If there are no other comments on this specific issue, I can move to a question by a colleague of ours who is working on foresight exercise. And she is asking, I'd like to hear the views of the speakers in public-private partnerships. I think it will be even more a necessity in the future. How to establish these partnerships? And then I don't see but this was the point of the question. I saw Moira probably was typing a reply. Would you like to share with all us?
We've particularly benefited from partnerships with commercial organisations, with private sector organisations, if that's what the question was about. So is it about technology suppliers as opposed to private health and care providers? I'm not absolutely clear, but we have benefited from engagements with technology types of commercial suppliers, and very often they haven't thought through or don't understand enough about the market that they're trying to develop their products for. So they're very enthusiastic in engaging with us to say, how do we do this together as a collaboration, rather than we come into a procurement exercise and we're trying to buy a product off the shelf. So as I said earlier, there's not a lot of products actually out there that's for this particular group of people or needs that we have been identifying. So we see it much more as what I would describe as innovation procurement. So you specify what the problem is that you're trying to solve, and then you look for partners who are prepared to work with you. Clearly, you need some funding in there, but you work with partners who are prepared to come with you and develop their product as they go, which then is much more satisfying for everyone. It meets the need of the individual, meets the needs of the services, and they can sell much more successfully than they would have been able to do on their own.
Alex, I know
sense?
you are also a big pioneer of public-private partnerships.
Not sure about pioneering, but I think it's important really. We need to elaborate further. I suppose now you'll understand my thought process here, is you understand further what private means. And for me, it was a steep learning curve talking to the business school at university and other stakeholders. But actually private could be an entrepreneur, could be a hedge funder, could be industry as we know it, the tech industry, a small, medium enterprise industry. And I think it's important that whenever you have those conversations, so for example, with the challenge con that I presented, there was a requirement that the university and the National Health Service and other social and healthcare providers need to team up with an SME, a small, medium enterprise, because I think that's where the results will come out, But of course, if Google or whoever, wants to support this initiative, I doubt it right now, but never to say never. It is important to explore what type of private organizations. Of course, there's a line, for me personally, a line. We're not talking here of the nicotine, gambling, alcohol industry. For me, that's a step too far to try and get money, soft money, because essentially I find it, there's a conflict of interest there going on.
Yes, thank you for mentioning the conflict of interest. That is surely an important concern for an organization public funded as ours. Catherine, do you have any comments on this?
Yes, from the sort of service provider point of view, I think people underestimate just how important it is. Particularly say with the nurses that I'm working with, like the nurses know what will work and what will not work, in a particular environment, are the service providers. So I think that that's the big tech companies are in a sense missing the opportunity if they're not involving sort of service providers and people who are using services in the design of their products. I think that it has to be a two-way thing. It's not just us going looking for the product. I think service product designers, the engineers and the big tech companies, they need to come to us and the service providers and the people who are using the services to say, look, what will actually work, what meets your needs, on a day-to-day basis.
Thank you very much. I have a long questionnaire from one of participants, but my suggestion is to give her contacts so that you can see. Alex, you are asking for the floor.
Yeah, very, very quickly. I'll give a challenge to the people who are with us around. Is one of the major challenges of all these medtech and digital products is actually battery and battery life. If we talk about engineering and tech, pure tech, I know it can be very dry, but that's major challenges. There are people who are developing long life, who are charging through LED lights, etc. How can we capture those new, innovative, disruptive technologies early enough so that we'll be able to use this technology for longer periods of time?
Thank you. And we don't answer now.
No.
Because I give the floor. We always love to leave our speakers and participants with more interest to follow our next webinars, and this is an excellent point. And I would give the floor to Thomas Clausen, our new chief scientist. You will tell me when you want to stop using the term new and for some conclusive remarks so that we conclude our webinar on time. Thank you.
Thank you again, Marika, for for that, and for the host and the experts and presenters also for an excellent webinar from my point of view. I've enjoyed and learned a lot, and I have also several questions that remain, and that will keep the interest and dialogue going, I guess. One of my observations would be that it seems like, so first of all, you are absolutely the experts, and you've been working for years, and you've shown us examples that are put into practice. But also hearing and learning from the examples, so I also get the impression that we're still only at the beginning. So this is a relatively new field, and there's going to be probably rapid and large developments in the years to come. So I expect that. And for that, I have two points before I end. The one is that we need to take the time needed. Also, in our normal services, in providing health and social services, we are very concerned that services are to be evidence-based and properly proven to work. And we need to make sure it's not only possible to implement, but actually show that they work over time and do whatever is intended, if it's saving lives or providing health or learning to people. So actually exploring that bits of it and testing it, we need to take that time. And then I see the time is going. So my question, because I had a little challenge to all of you, but we can have it to all of us. What do we see and think in 3 or 5 years is the main change within this sector? So tech and digital new interventions that will impact our field the most. I think that's we do foresights, as you said, Marika, here. I think that's going to be interesting to follow. I don't think we're going to take time to do it, but I'm looking forward to follow the sector, actually, and see how this is going to change and evolve. And I enjoyed a lot, and time has been flying for me at this end. Thank you all again, the experts, Moira, Catherine, Alex, and those were my wrap-up words. Marika, I don't know if there's anything else, Ines, or anyone to end this, but thank you all again.
No, I would like just to thank the speakers. I had 2,000 million ideas and projects listening to you, and I will bother you, as you know. Also, please, you and the audience and everybody, if you have ideas for webinars, this is our free space for conversations, so and ideas and collaboration. And so yes, it's an invitation. Use the frustration for all the questions we didn't answer to propose more ideas. I would also like to thank Ines for accepting to be the chair, and Anna, who is hiding somewhere, for having organized everything. And yes, I think we can close this.